things that we want to measure that outline good care. And we divided it up into the 4 areas of heart failure that complete, shall we say, a life cycle of heart failure. The 4 parts of heart failure would be the decompensation phase, when they initially get sick or initially develop the diagnosis. There is the inpatient phase. And you notice how these phases move into each other. They're not discrete. Someone can be unstable and an outpatient for several weeks. How many people have seen in their heart failure clinic someone who got sick and required several visits, and some of them got better and did not need hospitalization, and others got worse? Did that ever happen to you? No? Who here is in a heart failure clinic where that's never happened? So no one's putting their hands up. Okay, how many people in here have shoulder injuries and can't raise their hands? Nobody? Oh, okay. I guess they just didn't want to answer, I guess. The third phase is that transition phase between hospital and home. And we know now that the sooner that one is discharged from hospital, the greater the likelihood that they're going to be rehospitalized. That's particularly true in an American system where they really try to get them out very, very fast. In Canada and Europe, where the hospital stays are longer, the rehospitalization rates are a little bit lower. It's also a period of significant mortality. Up to 1/3 of mortality associated with acute heart failure happens after they go home. And then, of course, there's the 4th phase, which is the chronic, apparently stable phase, where they're coming into our offices and seeing us. And so we have performance objectives here. You can see here, this is the transition of care phase. These are not written in stone, but these are suggested things that we think are good that you should do to these patients. And so on and so forth. You can see the outpatient phase has the most because that's where the most grade A evidence is. In acute heart failures, there are certain items, there's a lot less of these, and as you know, there's very few level 1 grade A recommendations for acute heart failure. We've really been trying hard to find therapies that save lives in these patients, and we've been unsuccessful so far. Maybe next month we'll learn something new, who knows. And then, of course, one phase of heart failure that we frequently try to ignore is end of life. And of course, 60 to 70% of heart failure patients will die of a cardiovascular death. And so it's something that we must take care of. After all, when these patients are about to die, that is when they're the most helpless, and therefore when they need the most help. So, what can we see in the future? Well, there are several provincial initiatives, one of which is in British Columbia on the West Coast. They have developed a cardiac network, and they were kind enough to allow me to use this cartoon, which I would have been far too lazy to make myself. And you can see it is a set of distributed heart failure clinics. The tertiary care or the central heart failure clinic is in the big hospital. It is surrounded by regional heart failure clinics and then by embedded heart failure expertise within family practices. That is the way that they wish to go. That is a more of an integrative, some people call it a hub and spoke system, and that system is what they're going to go ahead with. Is there any proof that this is better than any other system? Not a single shred of evidence, but that's what they're going to do. And that's in keeping with some of the initiatives that other provincial governments in Canada have decided. They wish to redesign primary care to try to provide help at the family practice level, to keep patients closer to their homes and closer to their normal practice. So as heart failure dominates their clinical condition more and more, and in particular if it's refractory heart failure, transplant eligible heart failure, VAD eligible heart failure, or just difficult new onset heart failure, these people come closer to the tertiary and regional centers, and the ones who are more stable or whose plan of care has been developed and finalized, they are the ones that migrate more to their home setting. And we have a similar practice to that in Alberta, where we have now developed a heart network or a cardiac network in Alberta. We're about 10 years behind other provinces for this, but it was just created this year. And it is decided to focus on 3 areas, and number 1 of those was heart failure, because of the recognition that it is a huge cost, a huge burden to patients and to the healthcare providers. and the other two were acute coronary syndromes and cardiac imaging. In fact, we've developed now, and we do have a fairly, compared to some of the other provinces, a fairly good infrastructure of measurement capabilities, both for inpatient and outpatient. Alberta is one of the provinces a little further ahead in terms of electronic medical record province-wide distribution. And so we are quite confident that we are going to be able to pull data from emergency emergency room databases, the inpatient databases. Outpatient will take longer, like most places. And the transition, we have set up several optimization programs across the country looking at heart failure discharge processes and optimization. So that's where we are now, and these are the main outcome measures. There are many more outcome measures that we will be taking, and of course a lot of supporting data so that we can try to risk adjust our numbers. Just measuring mortality rates isn't fair if you have a far sicker group of patients than your next door neighbors. It has to be risk adjusted to make it look comparable. And we actually are, there actually is ongoing now in Alberta, a 10% of everyone discharged from a hospital in Alberta is sent a questionnaire asking about their care in the hospital, which is interesting, but probably quite expensive for what we're going to learn for it, is what I expect. Well, that's what we have currently. Now, as you likely know, there are about 35 clinics across Canada that are participating in the Heart Failure Network. It used to be called the Canadian Congestive Heart Failure Clinics Network, but we shortened it because it was too long to say, and we're all fairly lazy. So we call it the Canadian Heart Failure Network. And this is supported by a database that was based on, and similar to Vision C, which I saw some of demonstrated this morning. And a lot of the same elements are collected because we both groups use similar importance in terms of variables. The network is run by a series of committees. It shares the database. It also shares an interest in heart failure and heart failure clinic care, much the same as you guys today. And what we have found was that, number one, there is significant variation across the country. And number two, it's a powerful tool for actually looking at what happens to a heart failure outpatient. Because in this country, we don't have a good way of looking at that. So it's the best data we have and can be very informative. You can see that over time, since the clinics were started in 1999, that we've accumulated about 20,000 patients. It doesn't look like much. You can see it's very, very Caucasian in our patient populations. That's one thing about Canada. There's a higher percentage of ethnic minorities, which was just shown in our last session. About 16% now, 14%, 5 million Canadians are non-Caucasian or visible ethnic minorities. And you can see here that it doesn't look like much, but now we have a couple of thousand ethnic minorities, and that's something that you just don't see in clinical trials from Canada. Usually it's like 99% Caucasian. Serge, as a researcher, would see that every time and probably be frustrated by that. If you look at the etiology, and I'm not going to show you a whole bunch of slides, but we do have a fairly robust amount of data. 15% of our patients have preserved systolic function or diastolic dysfunction, whichever you prefer to call it. The average ejection fraction is in the mid-30s. The average age is 67. So it is a hybrid between a real-world heart failure population, which has an average age in the 70s, and a clinical trial population, which usually has its average age between 60 and 65 years of age, something like that. For example, in the SHIFT trial, I think the average age was only 60 in that group. So it's more representative of the real world, but not totally representative of the real world. But it is representative of what teams that have expertise taking care of heart failure are doing in their practice. And you can see that there's a copy of that slide. One other thing is that we have a collection, just like you, a collection of large clinics with several thousand patients. Now these are total patients, not active patients, divided by 3 to get active patients. okay? And you can see some with over 1,000 active patients, and then others that are either just starting or else not very large, they're in a smaller area. So there's quite a large variation, not only in practice pattern and in position, but also in clinic size. So I'm going to summarize then and suggest that in the heart failure network we have a lot of realized benefits. We have a network, we have a database, it's quite robust, there's a lot of information in it, it's been going on for some time. But we also have some real potentials to work, I think, much better than before. We can interrogate our database much more aggressively. We especially collaborate with other groups, and I think it's a natural that we collaborate. I think we can learn an awful lot from each other. The system of heart failure clinics, I think, in Quebec is a little bit different than in the rest of Canada, and therefore there would be quite an opportunity to look at that. And also trends over time, and not just geographic, but differences according to the way the healthcare system implements heart failure care can be looked at as well. So I think I'll stop there, and hope I didn't take too much of your time. Thank you very much.
Thank you. Parfait, par souci de temps, on va probablement se contenter de la présentation de Jonathan pour ce qui est de la France. On a déjà eu une certaine idée, on en aura une demain parce que tu vas présenter des données demain. Mais juste pour présenter, la similitude à travers les milieux, donc bien comprendre l'ampleur de la tâche, la clientèle qui augmente, la clientèle qui devient de plus en plus vieille. Vous savez que le symposium cette année, c'était la force du réseau. C'est un petit peu ça. Donc, notre réseau qui se développe, bien entendu, la possibilité avec le logiciel Vision C de pouvoir pooler les données de tout le monde et d'en sortir des données probantes qui vont nous renseigner sur la qualité du travail que l'on fait, mais non seulement ça, mais aussi sur l'importance de la comorbidité et puis la possibilité de collaboration, soit avec le reste du Canada et ou avec la France. C'est sûr que ça se voudrait une séance qui est interactive, donc je vous invite à aller prendre le micro si vous avez des questions. Bien entendu, notre réseau, vous le connaissez relativement bien, vous connaissez moins bien les réseaux canadiens et français. Donc, je ne sais pas si on pourrait rouvrir les micros pour la salle. Damien, en un mot, la réalité de terrain chez vous?
En un mot, ça va être difficile. J'y reviendrai un petit peu demain, un peu plus longuement, mais je suis toujours assez impressionné quand je vois autant de data épidémiologiques du Canada ou d'Amérique, parce que c'est vrai qu'en France, on n'a pas d'observatoire longitudinal aussi bien fourni. Je donnerai un exemple demain d'un observatoire, mais qui est vraiment un observatoire ponctuel. Alors, je ne sais pas si c'est je ne pense pas que ça soit lié à la culture latine française, puisque les Italiens font ça très bien. Mais c'est vrai historiquement, on n'a pas la culture de tenir des registres très précis. Donc on est encore un petit peu dans une période de balbutiement pour reconnaître la réalité de l'incidence cardiaque en France, qui est un petit peu dommageable, mais c'est comme ça commence à venir. Par rapport au réseau, puisque c'est quand même un peu le cœur du problème qui était évoqué là, il y a eu j'en reparlerai un peu plus longuement demain, on a des réseaux en France qui ont été initiés au début des années 2000, dans la suite de la littérature qui a été publiée à la fin des années 90, et des réseaux avec des expériences, avec des méthodologies différentes dans chaque réseau et des résultats également très différents. Jean-Noël, par exemple, avait été porteur d'un des premiers réseaux au niveau de la Loire-Atlantique, avec des résultats plutôt satisfaisants. À Paris, on avait une expérience de réseau avec un résultat plutôt décevant. Et toujours est-il qu'il y a eu beaucoup de réseaux qui sont mis en place progressivement, mais qui sont en train un petit peu de s'éteindre actuellement pour probablement redémarrer dans les années qui viennent. Alors pourquoi ils s'éteignent? Probablement pour pour plusieurs raisons. Un problème de financement. L'insuffisance cardiaque et les maladies chroniques en général, ça devient une priorité que depuis peu pour les financements publics. Et donc c'est le cas en France, mais comme ailleurs. Donc problème de financement, donc les gens se sont essoufflés dans des réseaux pour finalement pas grand-chose. Et deuxièmement, problème de méthodologie, parce que c'est vrai que c'est quand même compliqué. Qu'est-ce qu'il faut faire dans un réseau? Est-ce qu'il faut tout centrer sur une infirmière coordinatrice, tout centrer sur l'éducation thérapeutique, un peu des deux, faire intervenir l'hôpital, plutôt faire intervenir les généralistes, les cardiologues de ville qui ont une place très importante en France?